is how do you make the determination that you have a patient who needs biventricular support? Seems very simple, but it's very complicated, as you know, because a lot of the patients, about 80% of the patients, you can manage just with an LVAD and medications. So you have to be careful in selecting the patient. As you know, in the paper that we wrote in the Journal of Heart Specialty in November of 2018, for 450 TAH patients, 80% of them are either Intermax 1 or 2, so they're very ill. Okay, okay. So these are my disclosures. The other one that I have to do is CARMAT. So we're gonna present a patient. So this is the LVAD survival that from Intermax that we know very well. At 1 year is 83% survival. At 2 years, 73, and it slowly drops like this. If you look at, this is heart transplantation survival from ISHLT registry. This is where we would like to bring this technology, but we're still far away. Even with the current LVADs that we have, you can see there is a gap here between LVAD survival and transplantation. There are at least 6, and there are more now, parameters, indicators, or that trying to predict RV dysfunction post right ventricular LVAD placement. Okay, and you can see there is the Leadsmeter, the PEN, the Dracos-1, Cormos, and the reason why there are so many of them is because none of them work very well. So there is really no good way to tell you, oh, this is a patient who is going to develop biventricular failure, you better use biventricular support, versus someone who is going to get an LVAD. LVADs are pretty straightforward. Most echoes, when you read them, someone who is being considered for an LVAD said severe left ventricular dysfunction, dilated left ventricle, and when they refer to their right ventricle, they usually say moderate dysfunction. And that's as good as it gets. From an echo standpoint, you can use TAPSE, PAPI that we use, but at the end, really, nothing really tells you how bad it is, if it's gonna fail after an LVAD. So you have to determine, how am I gonna look? What am I gonna look to tell me that this patient needs biventricular support? That's what I'm trying to do. There are types of BiVADs out there. This is hardware with a tandem. This is 2 hardwares, and this is 2 HeartMate 3s. They seem to work very well, but it's interesting that when you look at survival, the survivals are very similar to the age survival. This is BiVAD outcomes with hardware. And as you can see, at 1 year survival for an LVAD by itself is 83% versus 58% at 1 year for BiVAD hardware, and so on. So, but the point here is, it is not the configuration of the device that you use that will have a major influence on the outcome of the patient. Does that make sense? It's not what device. You see, this should not tell you, oh, well, let me use an LVAD every time because the survival is better than the BiVAD. That's not the point. That's not the way to read this. The way to read this is the patient who get biventricular support are sicker than the patient who get an LVAD in most cases. Now, we all have done LVADs from patients who are on ECMO, Intermax 1, and they do well if you can see that the RV seems to be recovering on ECMO. If the RV is not recovering, then you have to start considering other options. So far, so good. Any questions so far? Any comments? Anything you want to tell me from your experience? Okay. This is BIVAS compared with, in the blue line is BIVAS hardware, okay? The red line is BIVAS with a hardware LVAD and a temporary support on the right side. You can see that the outcome is pretty much the same. This is, so comparing with other BIVAD series that have been done, and these are reported, that you have the references here, you can see that for temporary ARVA, when it was used, there were about 55.5% were Intermax 1 patients. For the hardware BIVAS, about 40%. And this was, Shah had a series of 46 patients with hardware, and 40% were stays. So you right there, you know that the mortality is probably gonna go up. When you take them, you wait 24 hours to go back and do the ARVA. And this is another series from Israel. 77% were Intermax 1. And actually, this is the one from Israel with HeartMate 3. And you can see the survival is pretty much the same. And again, the point here, it is not the device configuration, it is how sick the patients are going. You can see that you have a lot of Intermax 1 patients that you would probably not do with just a ELVA. So when you have Intermax 1 patient, you have to start thinking, is this someone I can get with an ELVA, and what information do I have that will be the case, or do I need to consider biventricular support? So let's look at patient selection. So what makes you start thinking that maybe this patient needs biventricular support? Is a patient on ECMO, and for how long? Yes, you can do an LVAD from a patient on ECMO. You have to show that the RV is okay. If the RV is not okay, hypocontractile, a lot of TR, low PA pressure, and you put them on ECMO, and the RV does not recover, you have to start thinking this might be biventricular support. How long have they been on ECMO? You know, many times I get called from different programs in the country, and they say, hey, we have this patient on ECMO for 3 weeks. The bilirubin is 27. He's anuric on CRT. What do you think if we put a TA? Well, that's a little bit too late. Right? The hemodynamics. You can look at, we can look at the hemodynamics to give you an idea of how that right ventricle is doing as a function of PAPI, central venous pressure, and so on. You can determine all those indices and parameters that I show you, but they have very limited predictive value. You look at the echo, you can look at the MRI, CT, and if they have disease on the right coronary, or the right coronary has been occluded, and there are minimal collateral from the left side, you have to start thinking, this RV might not work too well. And then one thing that we have added, and this is qualitative, I agree, is when you open the chest and you look at the heart, how does it look? Does it look like a fairly normal right ventricle? Is it kind of covered with fat? Is it dyskinetic? Is it only the area around the AV group that is moving? What color is it? Is it pale looking? So, and the argument here, you're gonna tell me, oh, but anesthesia always causes RV depression. Yes, we know that. But look, remember when you do a coronary bypass in someone with a normal EF, and you look at that RV looks fairly normal. In a sick LV, that RV might not look normal. So this is something that we use to help us determine what device we're gonna use. So many times we would consent a patient for both LVAD and artificial heart, for example. And we will make the determination in the operating room of what we need based on how bad this RV looks like, with echo and then visibly looking at the surface, okay? So we consent for both. This is in someone that we don't know for sure. We consent for both, we get financial approval for both, and we make the determination in the OR. So what are the indications for artificial heart support? Well, biventricular failure, you have someone that on echo, you see the LV is distended, hardly moving, and the RV is also hardly moving. That's someone that we'll consider TAH. Someone who is in profound cardiogenic shock, okay? Prior to having an organ dysfunction. So if they're in cardiogenic shock, they usually we put them on ECMO, see if we can stabilize and see how they do. And then from there we go. We do not use the total artificial heart to resuscitate patients like an ECMO, okay? That is a mistake that has been done. People run to the operating room, someone who is coding to put a TAH, okay? That is not a good idea. Temporize them, see how the organs are doing, so make sure that they wake up and the neural functions. Is a patient in the post-cardiotomy failure. They had an extensive valve replacement, second, third time redo with coronary or significant endocarditis affecting the aortic mitral valve area, that now you have this huge hole once you have debris in the field. And the patient is a transplant, could be a transplant candidate. Patient with malignant arrhythmia, they have been ablated 5, 6 times, and they continue to have runs of VT that affects their cardiac output. Sometimes we just go straight to TAH if the patient is a transplant candidate. Patient after a massive MI with a VSD, huge, large VSD, and otherwise they will be a transplant candidate. We will go ahead and reach them with a TAH. And patient with ventricular thrombosis, and this we have seen more with the increased use of ECMO, where you bypass the heart to a significant degree, and eventually you have biventricular thrombosis or partial thrombosis of one or the other ventricle. So other places that you can use it. Post-transplant vasculopathy, someone who needs a redo transplant, second time, is fairly young and has antibodies or is of a BMI that is borderline, and you're not too sure. Patients who have thrombosis from an LVAD with severe right ventricular failure, we have used them there. Complex congenital heart disease, and ET can probably address this too. Patients with cardiac malignancies, they have been done and then wait some time, and then decide to do them there. How long to wait is still controversial, and we can talk about that later. And then patients with multiple mechanical valves that you need, who have biventricular failure as a bridge to transplant, it works extremely well. Nowadays, what we're considering in the background is with the new UNOS allocation, if the patient is someone who might wait a long time, blood type O, between putting an LVAD or putting a TAH, if the patient has evident biventricular failure, we might put a TAH because then we can list them as status 2. A lot easier than putting them in status 3 and 4 after a month and then wait for a couple of years. So this is the competing outcome for patients who, let me look at this. No, this is from a manuscript in 2012, looking at survival on patients at that time. Oh, sorry. In this group of patients, I don't remember, 91% were Intermax 1, there were almost 8% incidence of stroke, and 68% of the patients survived to transplant. This is, I think, from 100 patients that reported from the University of Arizona, just to give you an idea. Now, there is better information that I'll show you in a minute. This is risk factors for morbidity and mortality that we identified from the 450 patients in Intermax that receive an artificial heart. Older age, if they're over 40 years of age, the risk increases. If they are on dialysis pre-implant, it is a risk factor for LVAD, it is a risk factor for TAH. If they are malnourished, It is a risk factor for LVAD. It is a risk factor for TAH too. So those are risk factors for actually morbidity and mortality for the TAH. Now, let's say you have a patient on ECMO. You're trying to decide, this patient could be a good transplant candidate, but the heart is completely failing. When is a good timing to say, okay, we've been on ECMO for X number of days, we should consider going to a TA. So we look at a series from Cedars in 2016, and we found out that the patient who did the best were patients from ECMO to TA, were patients who were on ECMO less than a week. After 1 week, then ECMO becomes a risk factor for survival, and the survival drops to about 50%. So that is the patient who's been on ECMO for 2-3 weeks with slightly elevated bilirubin, anuric, that is extremely high risk to do a TA. Okay, so but if it's between, at 4 days, for example, of being on ECMO, those patients tend to have better survival. What if you see a rise in bilirubin or high bilirubin? If the bilirubin keeps going up and up and up on ECMO, you have to be very cautious. Those patients are probably going to be at high risk. And what you have to rule out is that the gallbladder is not infarcted. One factor that we have identified in patients with cardiogenic shock that go on short-term support, if you see a rising bilirubin and rising white count that keeps going up day after day, you might look at the at an ultrasound of the gallbladder or a HIDA scan, and it might be non-diagnostic, but I can assure you that if you go and do a laparoscopy, most likely the gallbladder will be dead. And we have found that over the last 5-6 years to be pretty consistent. So you have to keep that in the back of your mind. It's not that the device is causing hemolysis that the liver cannot metabolize, is that the gallbladder is important. Any questions there so far? Okay. So what are the outcomes with total artificial heart that we know from Intermax? On the left side is centers that have done less than 10 patients. On the right is centers that have done more than, actually this should be 11, more than 11 and 10 or less. So when you look at the 1-year survival, this is a competing outcome for TAH from Intermax, you can see that about 46% of the patient will be dead at 1 year. If you look, the majority of those patients will die in the first 6 months, and then the curve stabilizes. Only 43% make it to transplant. So overall survival is about 53%, okay, that are alive on the device or transplanted. If you look at the centers that have more experience doing artificial heart, what we find is here in the red line, if they're gonna die, about 20% of them will die by 2 months, 1 or 2 months. And the curve will stabilize there. And more patients remain alive, more patients make it to transplantation, and more patients remain alive on the device. To about 68, 70% of the patients alive at 1 year. That is the center with experience. So what is that saying? That say, well, I only done 5 in my life and they're only poor, I should stop doing them. No, that's not what that means. You need to find out, well, what is it that these centers know that I don't know here? And that is, and this is just a survival looking center with more than 10 and center less than 10. And you can see the differential in survival until that was statistically significant. So what is the difference? The difference is, again, how long have they been on ECMO? Less than a week or more? Is a patient over 40? Is 60, 65, 70? Puts them at risk? Is a patient on dialysis going to TAH? Does the patient has a rising white count and bilirubin? Okay, so those are the things. So that's what we have found as the difference. that when you is selecting the patient, not letting the patient go too far. So the secret for TAH placement is select the right device and then do it in an early fashion. Don't wait days and days and weeks to decide that you're going to do a TAH. Most likely the outcome will be poor. So this is the same series that I showed you before, now with TAH added to it, and you can see that the 12-month survival is very close. Again, I don't have the 6-month survival for this group or the TAH, but you can imagine it's probably going to be, at least for TAH here, a little bit higher than the others, than this, because this is at 6 months. Now, again, this is if the center has experience versus no experience, and that is how you select the patient and timing for intervention. So the TAH cohort is not the LVAD cohort, okay? There are two different groups in Intermax. The LVAD is heavily Intermax 2 and 3. The TAH is heavy Intermax 1 and 2. There are structural issues that you might decide when to use a BiVAD or a TAH. In the BiVAD, you leave the heart behind, and you have to match the output from the both baths. And so the TAH is a lot easier. If you have a patient who is Intermax 1 and 2, at least ask your question, rule it out. Is this a patient for a TAH, or is this someone who can go well without an LVAD? Structural issues. There are post-infarction BSDs. Is this an amyloid patient? If it's an amyloid patient, we have very good outcomes using the TAH to bridge to transplant. And the risk factors that we discussed: age over 40, dialysis pre-implantation, rising bilirubin, malnourishment, and ECMO more than a week,